I'm Dr. Allan Perel, and this is Conversations in Medicine. Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the tri-state and Staten Island community. Today's program is about peripheral vascular disease and vascular disease as a whole, diseases of the arteries and the veins. Peripheral arterial disease affects over 10 million people, mostly over the age of 50, but even some younger people. We all have this fear of amputation. We watch television shows about cigarette smoking, but sometimes some of the symptoms are more subtle, like leg pain. Venous disease, or diseases of the veins, talks about anything from varicose veins to blood clots, and we're going to talk about them tonight. It's my pleasure to bring in my guests, two prominent vascular surgeons on Staten Island, Dr. William Rodino and Dr. Frank Tarantini. Thank you for coming by.
Thank you for having us.
Thank you. So we're going to jump right in. You guys are vascular surgeons. We're talking about arteries and veins. Fits in the criteria of what a vascular surgeon would do. How do you become a vascular surgeon?
Well, a vascular surgeon is a surgeon who specializes in the diseases of the arteries and the veins. Traditionally, after you go to medical school for 4 years, you do a surgery residency in general surgery, and that's a 5-year training program. And that's basically, surgery involving the intestines and all different aspects of the body, and then you then specialize for 2 years in vascular surgery. And vascular surgery is where you just deal with the blockages in the arteries, aneurysms in the aorta, which is the big blood vessel in the belly. Patients who have blockages in their carotid arteries. So basically it's 7 years of training after medical school.
And you almost exclusively deal with arteries and veins now that you're out in practice.
Yes, exactly. The only thing different now is the training is a little different because it's more minimally invasive. So you're doing things more not in the open surgical aspect of open aneurysms or open carotid artery surgery or even bypasses for the legs. We do things where it's more percutaneous, where it's just putting like an IV through an artery or a vein and treating it that way.
As a neurologist, we deal a lot with carotid artery disease, and as you said, a lot of patients aren't going through the endarterectomy, which is the cut to take the clot out. Now they're doing stents, and which is what we think about with hearts, where they open up the blood vessel, where you open up the blood vessel.
Correct.
Using a little balloon.
Like a balloon. This is actually a balloon that we use for arteries. This is more used in peripheral arterial work in legs. And basically, this is like a model where this is an artery where it's a normal artery, and then there's some what's called plaque or atherosclerosis.
What makes up the plaque?
Well, it's what happens is it's hereditary, it's cholesterol, it's nicotine, it's all these many risk factors that can lead to this. And there's a lot of medical management that we can talk about before we get to this. There's anti-cholesterol drugs, antiplatelets like aspirin, a drug called Plavix, other drugs called Platel that we use for patients who have what's called claudication, when patients develop cramps in their calves after walking a block or two. And that's because their muscles aren't getting adequate blood supply. So the muscles are calling for more oxygen, it's not getting there. So to get more oxygen there, you can use some of these medical management, and in addition to that, exercise also helps. So the more they walk, the better. But there are some patients that doesn't work. And then we get to our intervention.
So show us, you were kind enough to bring in things, and we talked about things, instead of doing the open procedure where you have a large wound or cut, this goes through an artery,
this goes through an artery.
Groin.
Let's just say that this is the femoral artery. So we would go through the opposite side of the of the groin, which is, let's say this is the right, we go through the left, and we go up and over the main aorta, which is the main vessel, and we navigate a catheter into the artery, and we take pictures, which is an angiogram. And then when we find this blockage, which is significant here, and sometimes it's totally blocked, and we're still able to get through. And then we just insert this. We connect our, now this is all outside the body. This part is outside the body. And we connect this. And we inflate the balloon in here.
So it tells you it takes a team of people to do it. You can't
It
do
does.
this on your
It's
own.
not done by yourself. There's a team. And you inflate this balloon to a certain amount, and then you release it. And then we take a picture and see any improvement. If there isn't, sometimes you need a stent. And a stent just goes in. It's a device that is made up of metal and a couple of combinations of things that is implanted inside your artery and opens it. And most patients do very well after that. They require monitoring. We have to keep an eye on their circulation. Sometimes they need reintervention, but for the most part, we save them a big operation, which is a bypass, and hopefully the worst outcomes are amputations.
Where are these procedures done?
Well, most of these procedures are done in our office. It's a procedure that can be done under minor sedation and local anesthesia. Some of them require hospitalization, but for the most part, I would say 90% are done in an outpatient setting.
So isn't that amazing over the years that we've been in practice that you could actually do this type of procedure in someone's office and go home that day?
Absolutely.
Well, you know, when I first started practicing vascular surgery over 20 years ago, this was just very new, and most patients would end up having bypass operations to do this, to open up blockages that Dr. Tarantino was talking about. Those patients would actually have to stay in the hospital for over a week. They'd have large incisions in their legs, and then they would have to go to physical therapy, which might be another month. And the recovery was so long, and you know, the patients that you know, undergo the angioplasty and the stenting, you know, they're doing it the same day, walking right away, with none of that extra recovery time.
What's interesting, so many of our people, the people who are watching us, all know about coronary artery disease, angina, heart attacks with myocardial infarction, and they think about stents with heart issues. I think we're bringing them to light a little bit that you could put a stent in different arteries and really make it work the same way that a stent or an angioplasty or a balloon to open up an artery that's closed because of plaque or narrowing. In the heart, it's really the same thing you could do for the carotid arteries, as
Exactly.
a neurologist we see a lot,
Yes.
and you do for carotid arteries and peripheral arteries.
Well, you can do that for, yeah, like you said, the carotid artery, arteries in the legs, even in the arms. Sometimes there's patients who have what's called renal artery stenosis, and we can do that for the arteries to the kidneys. And there are a lot of other things we can do. If you talk about like aneurysms, there's aneurysms that can occur in all parts of the body.
What's an aneurysm?
Well, an aneurysm is basically a weakening of the wall of an artery. So the artery weakens and it just expands and it balloons out. And the risk of certain aneurysms are rupture, and certain aneurysm risks are not rupture, they clot. And one of the areas where they can clot is in the leg, and that's another area we can use stenting as well, and saving a patient from a big operation.
You know, I just want to add that with vascular disease, there's one common denominator that causes a lot of these problems, and that's cigarette smoking. And what Dr. Tarantino was discussing, with aneurysm formation, the biggest cause of aneurysms forming is cigarette smoking. The major cause of atherosclerosis or hardening of the arteries in the leg is cigarette smoking. You know, carotid artery disease. So, you know, that's the major risk factor. And, you know, when we treat patients with vascular disease, not only do we, you know, want to, you know, cure them with an angioplasty or whatever modality we have, but we want to encourage them to stop smoking, because that's the biggest culprit.
Sometimes use the word modifiable, non-modifiable things. Non-modifiable, that's your genetics, your sex, your age.
Correct.
Modifiable things is your cholesterol level, your high blood pressure, and smoking. So what if you do a procedure like this and someone continues to smoke? What happens?
they re-stenose. They start the stent or the artery, if it's not stented, starts to form scar tissue and reaccumulates plaque, and it happens. And it can happen fairly quickly. So, and it's not to say that, honestly, if someone does stop smoking, that won't occur, but it'd occur much less.
You're taking one precipitating factor. Cholesterol could still be either. There's genetics
Correct.
of this also. There's a
Right.
lot of
There's a
things
lot of
that
risk
go into
factors, right.
it. How interesting. So we're going to actually go a little bit forward and then back. How does someone know when to go to a vascular surgeon? How would you know whether if my legs are hurting after I walked a few blocks? Do I go to a vascular surgeon? Do I go to my internist? Where do I go?
Well, I think, a lot of patients start with their internist, so they might go, have pain in their legs, and they go to the internist, and the internist is sort of like the preliminary assessment. A lot of times, leg pain is a very difficult symptom to diagnose, because leg pain can be caused by a lot of different things. You have vascular conditions, both in the arteries and the veins, that can cause leg pain. Dr. Tarantini mentioned about, patients who have blockages in the arteries in the legs. Well, they're going to get a type of leg pain where when they walk, they're going to get tightness in their calf, like a Charlie horse. They may walk 2 blocks, they get the tightness, they stop, it goes away. There are patients who have vein problems who will also have leg pain. The leg pain is a little different. They may have some tiredness, heaviness, achiness, swelling in the legs that, occurs towards the end of the day. But patients could have back problems. They get pinched nerves. They could have orthopedic issues, arthritic conditions. So I think what happens is the internist will see the patients first. If they're not sure if it's vascular or something else, they'll send it to the vascular surgeon, and then, based on, our diagnostic testing and our examination, we'll determine whether it is or isn't.
There's an interesting phenomenon called pseudo-claudication or fake claudication that I see in the office. People with lumbar or spinal stenosis, sometimes they walk a block or two and they'll have that same kind of pain. And then they sit down and they get better. And there's certain other signs with regard to it, like numbness in the legs, reflex problems, weakness. But it's interesting that we see very similar patients in a lot of regards. People that you do a workup for and don't find anything, or I do a workup for and don't find anything, we then send them over to the other guys, to you guys, and see.
Exactly. We see that a lot, actually, where they talk about typical claudication, but it's pseudo pain, because once you do the physical exam and you see that they're normal pulses, you do an arterial study and that's fine. Then you dig deeper and they say, yeah, my back a little bit here, it hurts a little bit, and there you go.
Tell us about pulses. In medical school, when kids, they play with their pulses. Where are pulses? And are there pulses everywhere, or are there pulses just, you think about your wrist where a nurse would take your blood pressure and your pulse. You say, are there pulses in your feet?
Well, there are pulses in your feet. There are 2 specific areas where you can feel it if there is one there. It's one overlying the forefoot, right along the forefoot, and one on the ankle, on the medial inside ankle part. If those pulses are bounding and you can feel it, it's unlikely that there is any kind of peripheral arterial disease. And if they're having any symptoms or numbness, it's probably musculoskeletal related. But when you do have a distinction where there's what's called a femoral pulse in the groins and you don't feel a pulse behind the knee, that's definitely an indication that there is some blockage. And it depends on when that occurred, when they lost their pulse. If it was something that occurred like months and years ago, they're not going to have that many symptoms. They're going to say, yeah, it hurts a little bit when I walk a few blocks, but that's because their blockage occurred over a long period of time. So if the patient came in and said their pain is just happened 3 days ago, then something happened, and that tells us that there's an acute phenomenon going on where it's a clot, some clot went down and caused what's called ischemia, or no flow to the leg.
And the pulse exam sometimes can be unreliable. I mean, you'll have patients who are diabetics and they have a lot of calcium in their arteries, and they may be open, but the arteries don't really transmit the pulse. And there are also some patients who have a lot of leg swelling, and you may not feel the pulse. So, we have a vascular lab in our office, and basically we have machines.
Tell us about the testing.
So we have different machines that sort of look at different areas of the vasculature. So if we're looking at somebody with arterial disease, a preliminary test that we do is something called a pulse volume recording test. And basically, we put blood pressure cuffs on the patient's legs at various levels. There's two at the thigh, one below the knee, one at the calf, and one at the ankle. And they record pressures, and they generate a waveform that can give us an idea of whether the circulation is normal, and if there is a blockage, at what level. Because the blockage could be all the way up in the abdomen, it can be in the groin, it can be at the knee, or even lower down. Then we have an ultrasound machine, which a lot of people call a Doppler, but basically that looks at blood flow in both arteries and veins. And if we have a patient who has, if we're concerned about a blood clot in the vein, a DVT, then we use the ultrasound, and our ultrasonographer will look, our vascular tech will look at the veins all the way from the groin down to the calf. Examination is, getting the patient's history and seeing what their symptoms are, examining them, and then as vascular surgeons in our armamentarium is also our vascular lab and our diagnostic testing.
And it's of course important to have qualified people doing that, because it's really a lot of this is technician dependent.
Yeah,
how they do it.
Our vascular techs just do
That's all they
vascular
do.
testing.
Tell me about amputation. The biggest fear everyone has is that, as you watch on TV, the commercials for smoking in New York, where that people are going to lose a finger, lose a foot. You think about people with diabetes, people with cigarette smoking, which is what the commercials are for. We'll have an amputation. Thank goodness over the years, again, it still happens, and someone who goes rounds in the hospital. I'm the chief of neurology over Richmond University Medical Center. I know you guys are all on staff there. I'm seeing less and less of it.
Yes, absolutely.
And tell me, is that because of intervention?
I think it is because not only of intervention, but early prevention. Getting to the patient when they're first diagnosed with diabetes, or trying to get them to stop smoking, those sort of things. And early intervention too. Once they're keyed in on a vascular surgeon who's going to follow them and keep an eye on their legs and their circulation. And at any point when there's a non-healing wound in a foot, that's when we think about maybe intervening to get that to heal. Because once there's a wound in the foot and that can get infected in a diabetic.
Why doesn't a wound heal? Maybe tell me, Dr. Rodino.
There are a lot of different factors. I mean, the one thing as vascular surgeons we want to make sure is that the circulation is adequate. Because if you don't have enough arterial blood flow getting down to the ulcer, it's not going to heal. And ulcers have to, there's something that ulcers have to form that healing tissue. We call it the granulation tissue, and they need blood supply. They need oxygen, and they're not going to heal. Ulcers may not heal also because of pressure. Diabetics tend to get pressure ulcerations because they don't have good sensation, and constant pressure on a wound will prevent it from healing. Then there are patients who have tremendous amount of swelling in their leg, and the swelling that builds up in the wound will prevent it from healing. Nutritional factors. I mean, there's a lot of things that go into wound healing, but as vascular surgeons, the main thing is there enough blood flow? Is enough oxygen getting down there? And if it isn't, then we have to do something to correct that.
And that's so crucial, having blood flow, even if someone, why do liniments help and things like Bengay that try to increase blood flow to even your sore muscles. So again, even something as simple as that. We're going to move on now. We're going to talk about veins. So maybe have Dr. Rodino, you and Dr. Tarantini, such experts in the field. Give us a couple of minutes on what's an artery, what's a vein, and what's in between.
Well, it's all part of the circulation, right? So you have the heart that's pumping the oxygenated blood, the blood that has gone through the lungs and is now full of oxygen. That has to get throughout the body, and the heart pumps it through the arteries. And the arteries, travel all over, whether they go the arms, the legs, the organs in the belly. And eventually, after they deliver the oxygen to those tissues, it has to come back. And the blood that comes back, which has less oxygen in it, goes through these tiny little blood vessels called capillaries. So when you think about it, at the heart, the arteries are very big. And as they go to the more further areas of the body, they get smaller and smaller until they become microscopic. And then they connect with what we call veins. The veins bring the blood back to the heart, and that blood has less oxygen. So, it's anatomically there are, or histologically there are different arteries are thicker, veins are thinner. When we do open operations and we dissect them out, it's there's a clear distinction in the characteristics of the two. But basically, one is bringing blood, the arteries are bringing blood to the organs, and the veins are bringing them back.
So in terms of the arteries supplying oxygen, the veins bring blood back. So I'll ask you the simple question that when I think a third grader once asked me, why are your veins blue?
Well, they are thin-walled. The veins that you see, on your hands or your feet, are very close to the skin. And these thin-walled veins that have the deoxygenated blood, which isn't as bright red as the blood with the oxygen, give that appearance of blue. One of the things that we see, and actually I saw a couple patients in the office today, is that a lot of patients, they come in and they say, oh, my feet are blue. And they get very concerned, and they think, well, my feet are going to fall off because I have very poor circulation. But basically what they'll have is that they'll have what we call venous insufficiency. The veins are weak, and what happens is that this blood that doesn't have as much oxygen in it kind of pools in the feet and gives it a bluish appearance. And we always tell those patients, well, if you elevate your leg, you'll see that bluish color will go away because gravity is bringing the blood back. And it's just...
And we stand on our feet, and they're pretty far away from the heart and all those other things. So veins. People talk about their veins all the time. People have varicose veins. People have spider veins. Everyone's legs look different when they're 50 than when they're 20. Tell us about veins.
Well, like Dr. Rodina was saying, one of the issues is the return of the blood back to the heart. There's an issue. So in the veins in the legs, there are valves, and there's in the legs, there are what's called the deep vessels and superficial vessels. So the superficial vessels are the ones under the skin. They're not necessarily, we're talking about the ones that you can directly see. It's just a term that is an anatomic term. And those particular vessels have valves in them. And the valves open and close. So when you're sitting or standing, the valve closes. So the blood is not supposed to leak, so to speak, back down. It's supposed to keep going up to the heart. So when those valves are quote-unquote leaky, the blood pools back down, causing patients to have swelling, bluish discoloration, depending on how long the process has been going on. If it's a long process, they can have changes in color in their skin. They can have a point of breakdown of their skin and have ulcers. Now, I'm not talking about ulcers in the foot, above the ankle. Those are usually called venous ulcers. But that's the chronic part of it. The ones that come in where they have pain and swelling and veins that are throbbing occur because this back pressure of the blood coming back down the legs causes the legs to swell, causes those varicose veins that really maybe
What is a varicose vein?
It's a vein that has become tortuous, has become superficial, and is right under the skin that can cause pain. There can be some what's called stagnant blood flow in them where you can get clot formation, and that's when people get what's called phlebitis sometimes, which can be painful, but treatable.
When we talk about veins, everybody on the plane, every plane ride I've gone on, there's always one person who comes on with this running sneakers, pair of shorts, and decides to walk up and down the aisle 150 times. Now, tell us about the risks of being on a plane or sitting for a long time in what's called deep vein thrombosis or DVT. They use different letters now for it. Tell us about it a little bit.
Basically, for the blood to circulate back, your muscles have to be contracting. On a plane, if you're flying to Europe and you're on a plane for 8, 9, 10 hours, you're sitting in one position and your muscles aren't contracting. So what's happening is that the blood in your legs is just kind of pooling in there. Now blood, if it doesn't circulate, eventually it's going to clot. And so you have these veins in your legs that can be pretty big, especially up near the groin area. And if they clot, then that clot can not just stay in the vein, it can break off and it can go to your lung, and that's something called a pulmonary embolism, and that could be fatal.
That's what happened with Serena Williams recently.
Yeah,
I think that was the
and
news.
so it blocks the veins in the lung, and it puts strain on the heart, and you can stop breathing. Your heart could stop. So we're actually seeing more and more. We'll see patients who go on these long plane rides or car trips. I've had patients who tried to drive nonstop from New York to Miami, and they get out of the car and they have massive leg swelling, and all of a sudden, they go to the hospital and they have a Doppler test and they find a blood clot. So there is definitely a risk there, and we always recommend patients who go on these long trips to do certain maneuvers. One thing that's very good is to wear a support stocking. A support stocking puts pressure on the calf and helps stimulate the circulation. If you're on a big enough plane where you can get up and walk around a little, that helps. But the main thing is awareness, so that if you do come off a trip like that and you have this leg swelling and pain, this is unusual, you probably should go to the emergency room or go to a vascular doctor and get an ultrasound.
We hear a lot about vein therapy, so we have only a couple of minutes left. Maybe you could show us what you brought.
Well, everybody knows of somebody many, many years ago who had a vein stripping procedure, and basically what we were mentioning before about how these veins aren't directing blood and the blood is going backwards. Well, the treatment for that would be to remove that vein and to strip it. But for the last probably 10, 12 years, we've been doing something called an ablation procedure. And basically, instead of removing that vein, and when you removed it, you had to make a whole bunch of incisions and take it out. And it was, the recovery was very long. Now we have something called an ablation catheter. And basically what the catheter is, it has a heating coil on it. And it's very thin. And it goes through a tiny little puncture site right around the knee area. And we direct it under ultrasound it gets to right in the groin area. And this coil then, this is connected to a generator, and it generates electrical current. This is called a radiofrequency ablation catheter. And we hit the button, and it heats up the vein and starts sealing the vein. And we pull it back, and this is about 7 centimeters long. We pull it back systematically throughout the vein, and it seals the vein.
And it's a less invasive procedure.
Yeah, because just to give you an idea, patients who had the stripping procedures, although they went home the same day, they'd be out of work for about a week. Patients who have the ablation, since we don't have to do any cutting, we just tell them, no heavy lifting for 48 hours, bring you back to your normal routine. So the recovery is very quick, and it does the same function as the stripping.
I think I told you when we started, this is the fastest half hour. We're coming to the end. I want to thank you both for being here. It was wonderful to talk about arterial disease and how we've reduced the number of people who need open procedures, amputations, aneurysm treatments, and venous disease, which used to be this heinous thing with cutting and everything else. Now, burning these veins away, being able to be it both aesthetically and also with regard to pain, doing better. So thank you guys for coming. Really appreciate it.
Pleasure.
Thanks
Thanks.
again.